In a patient who presents with postmenopausal bleeding, which is defined as vaginal bleeding more than 1 year after menopause, there needs to be a high level of suspicion that there may be endometrial carcinoma developing. However, the differential will include vaginal atrophy, which will be the most common in a postmenopausal woman. However, 80 to 90% of patients who have the diagnosis of endometrial carcinoma will present with a chief complaint of abnormal bleeding. The demographics of endometrial cancer or carcinoma are going to include women who are 50 to 70 years of age. Other risk factors are going to include obesity, nulliparity, diabetes, polycystic ovaries with prolonged anovulation, a history of unopposed estrogen therapy, and extended use of tamoxifen for treatment of breast cancer. Women with a family history of colon cancer, HNPCC, or Lynch syndrome, are at significantly increased risk with a lifetime incidence as high as 30%. As earlier noted, postmenopausal bleeding will be the most common symptom that will present in a patient with endometrial cancer. The incidence of endometrial cancer in postmenopausal women with irregular bleeding ranges from 4% to 25%. Pelvic pain is typically a late manifestation of the disease with either infection or metastases as comorbidities resulting in the pelvic pain. Obstruction of the cervix with a collection of pus or blood causing a lower abdominal pain may also occur. And so on our differential, we need to consider endometrial hyperplasia, cervical cancer, vulvar cancer, an estrogen-secreting tumor, and again, vaginal atrophy being the most common cause of postmenopausal bleeding. The studies to get in the workup of postmenopausal bleeding are first and foremost going to be endometrial biopsy and an endocervical curettage. This is going to be because of a large prevalence and dangerous risk of missing endometrial lesions. We're going to get a pap smear to rule out cervical dysplasia and neoplasia, an abdominal and pelvic ultrasound, and potentially hysteroscopy or CT for further imaging. Transvaginal ultrasound to determine endometrium thickness can have a predictive value. In postmenopausal women with vaginal bleeding, the risk of cancer is approximately 7.3% if her endometrium is thicker than 5 millimeters and is less than 0.1% if her endometrium is thinner than 0.5 millimeters. If after endometrial biopsy cellular atypia is observed, a D&C and or hysteroscopy should be the next step. Endometrial hyperplasia without atypia can be managed with progesterone therapy. Endometrial hyperplasia with atypia should include the following steps: dilation and curettage to gain a better sample of the endometrium to rule out cancer. If there is a goal to preserve fertility, a high-dose progesterone should be used. However, if a woman is done with her childbearing, a hysterectomy is going to be the best option. In a woman with diagnosed endometrial cancer, the recommended components of a surgical approach are going to include a extrafascial total abdominal hysterectomy, bilateral salpingo-oophorectomy, collection of abdominal and pelvic washings, and pelvic and para-aortic lymphadenectomy. An omentectomy is indicated in patients with obvious metastatic disease or high-grade lesion on initial biopsy. In a woman who is diagnosed with a low-grade endometrial carcinoma, one of the first steps of follow-up should be to obtain a chest x-ray, as the lungs are one of the most common sites of distant metastases. Further, a CA-125 can be indicative of advanced disease when it is noted to be elevated. So in summary, 90% of patients who are diagnosed with endometrial carcinoma have a presenting symptom of irregular postmenopausal vaginal bleeding. Most often occurs in women 50 to 70 years of age. Risk factors include obesity, nulliparity, diabetes, polycystic ovaries with prolonged anovulation, unopposed estrogen therapy, extended use of tamoxifen for the treatment of breast cancer, early onset of menarche, and late onset of menopause. Studies to get in workup are endometrial biopsy, an endocervical curettage, a pap smear to rule out cervical dysplasia, a transvaginal or transabdominal ultrasound to determine endometrial thickness. Greater than 5 millimeters has a higher risk of positive findings as opposed to less than 5 millimeters, it is much less likely. Hysteroscopy should be done if there is atypia found in the endometrial sample. With atypia, dilation and curettage should be conducted in order to gain a better sample. In women who are hoping to preserve fertility, progestin-based oral contraceptives can be used in high doses to try to reduce endometrial thickening. Surgery is a definitive option with total hysterectomy and bilateral salpingo-oophorectomy being the best option. With early diagnosis and treatment, the 5-year survival is 80 to 85%. In terms of prevention, prompt endometrial sampling for patients who report abnormal menstrual bleeding or postmenopausal uterine bleeding will reveal many incipient as well as clinical cases of endometrial cancer. Younger women with chronic anovulation are at risk for endometrial hyperplasia and subsequent endometrial cancer. They can reduce the risk of hyperplasia almost completely with the use of oral contraceptives or cyclic progestin therapy.